to all also Muslim brother everywhere in the world. And thank you for our speaker and panelists. They are participating with us today in this webinar meetings. Also in Ramadan, this is the first webinar we are doing in Ramadan, and we will have another one only in Ramadan. Then we'll take a break. Then we'll come back only after the Eid, inshallah. The second one, it will be next week on 23rd. It will be a posterior and anterior segment symposium. Just before we start, I'd like to ask every one of my dear colleagues here to introduce themselves for our attendees. I will start by our guest speaker, Dr. Ramzi. If you can just give a hint about yourself, otherwise I will read.
So, thank you. Good evening for everybody. And I work in the University of Urdu University for 20 years of my academic career, and then left the university almost 10 years ago. Then I founded a hospital, private hospital. Now I'm a director and also founder of this hospital in Bursa, Turkey. And we have 12 eye specialists, and we have all sections that we work together, but mainly enlarged retina, is medical surgical retina in our department. But also we can do refractive surgery and other anterior segment surgery. And still I'm continue to writing article and meetings and others, but not so active like in the university when I was in the university. So I'm happy to be here because I want, I think Dr. Mohammed invited me, maybe this is the third or fourth invitation during this COVID pandemic period. And I really enjoy to be here and to join to discuss and share my experience with you. Thank you again for this invitation, Dr. Mohammed. And
it's our honor and pleasure, Dr.
Okay.
Ramzi. Thank you for being with us. Dr. Mandeep.
Good evening, everyone. Ramadan Kareem. I am Dr. Mandeep Lamba. I am a vitreous surgeon working with DHA, Dubai Health Authority at Dubai Hospital. And we have 6 super specialty teams. I'm a part of surgical retina, precisely. I hail from India, basically, and was basically brought up with an organization called Dr. Agrawal's Eye Hospital in India. Left it in 2016 as a medical director in Hyderabad, moved to UAE, and since then I'm a part of DHA.
Thank you, Dr. Mandeep. Thanks a lot. Dr. Amr.
Good evening, everyone, and Ramadan Kareem. And thanks for Dr. Muhammad for the invitation. Thanks for Al-Argan as well for the invitation. I'm Dr. Amr Farid. I'm a retinal surgeon in Maghrabi Eye Hospital in Dubai. Before I worked also in Maghrabi, Saudi Arabia. Then I moved here about maybe 9 years ago. Welcome, everyone.
Thank you, Dr. Amr. Honor also. Dr. Muhammad Hazazi.
Thank you, Dr. Muhammad, for invitation. I'm really happy to be with you today. I'm Muhammad Hazazi. I am assistant professor in King Abdulaziz, Saud bin Abdulaziz University in Riyadh. I'm also a consultant veterinary surgeon and National Guard Hospital. I'm honored to be the chairman of the Saudi FDA committee in Saudi Arabia. I'm also the chairman of the Saudi Retina Symposium held in Riyadh. Thank you for the invitation. I'm really happy to be with you.
Thank you very much, Dr. Muhammad, and honor and pleasure to be all with us. We are still having Dr. Ahmed Salam. He will join us a little bit late. He is in US and he is now the time of praying, I think, Jum'ah prayer. So I think we will start our session. And the first talk, it will be by our friends and Dr. Mandeep Lamba, and he is going to talk about long-term outcome of dexamethasone implant. Dr. Mandeep, you can start, please.
So can you see my screen? Am I audible, Dr. Amri?
Yes. Yes.
Okay.
Just I'm ask all my colleagues to be mute, then only Dr. Mandeep, he will give a talk. Thank you.
Right. Thank you, Dr. Amri, for providing this forum. Thanks to the team Allergan for making this happen to allow us to share our experiences. Ramadan Kareem, everyone. I really hope this Ramadan gets us some blessings, help us fight this menace of COVID-19, which we have been suffering from past year or so. We all need it. The purpose of this talk actually is to put forward the data that has been published in the recent past few years, indicating the early use of OZURDEX implant in the management of diabetic macular edema. We all need this particular look into this particular aspect of OZURDEX, because we don't need our patients to come and see us on a monthly basis as we normally used to do previously. Most of our patients are comorbids, diabetics, etc. They themselves don't want to turn up every month fearing COVID and on and off surges of COVID every now and then. So this particular topic basically excited me for a particular reason. There was an article published in 2011 and 12 in the journal I, which spoke about close to 18 different kinds of inflammatory direct and indirect mediators causing diabetic retinopathy, diabetic macular edema, and the progression of DME. Unfortunately, 10 years later, a decade later, we are still trying to treat our patients by hanging around by treating only VEGF factor, and we have neglected probably the rest of 18 or 19 of them. The good part about use of dexamethasone implant or steroids in general in management of DME is they allow us to handle some of the other mediators other than VEGF and VEGF2. So when you look into if I can borrow a line from the EURETINA guidelines, it said that the use of corticosteroids in the treatment of DME may be more comprehensive than anti-VEGF treatment, which targets only a part of inflammatory cascade. So when we talk about corticosteroids, they decrease VEGF synthesis. They also decrease the synthesis of other inflammatory mediators. They decrease the inflammatory process, and which eventually significantly improves the integrity of blood-retinal barrier through the inhibition of expression of ICAM receptors. When we talk about corticosteroids, unlike VEGF, it also has a direct impact on pro-inflammatory cytokines like interleukin-1 beta, TNF-alpha, and IL-6. All these integratedly reduces the vascular leakage, hence controlling the diabetic macular edemas. Unlike what we believe, corticosteroids also have anti-VEGF activity, not to the proportion as anti-VEGF agents, but they have anti-VEGF activities sufficient enough to give us a good resolution of diabetic macular edemas. So to summarize, use of OZURDEX or intravitreal steroids per se inhibits the inflammatory cell proliferation and migration, reduces intracellular swelling, particularly of Mueller cells, reduces breakdown of blood-retinal barrier, and it targets local inflammation by reducing extracellular and intracellular edema. All these theoretical concepts do translate into our clinical practices as well. This particular data published from Verity et al. Shows us that once you inject OZURDEX into the vitreous cavity, the effect is seen within hours, as early as 72 hours. In fact, they showed certain cases where they could find a significant improvement in central macular thickness within 72 hours of injection of OZURDEX. They also said that you can achieve up to 10 ETDRS letters on an average gain at day 14. So OZURDEX does gives us a prompt response. Needless to say, based on the above findings, EURETINA recommended OZURDEX as a main ingredient for treating DME, especially can be used as a primary mode of treatment for pseudophakic patients. It is the primary mode of treatment for patients who have major cardiovascular risk factors and who have contraindication for anti-VEGFs, and for the patients who are not willing to come to us on a monthly basis, especially in this COVID era. We have a lot of such patients who want to do that. One of the broad and the main indications of corticosteroids was the patients who have not responded well to anti-VEGF agents, especially in the first 3 months. So some of the recent data has shown us, especially Bush et al. Had published this particular report, which says that you inject, once you take these patients who have undergone monthly injections, 3 monthly injections, and have not shown a good response, and you switch these patients to OZURDEX, they show a significantly better response as compared to treatment with continuous anti-VEGF therapy. Simultaneously, they also showed that there was a significant improvement in the central macular thickness on OCT in the OZURDEX arm as compared to continuous anti-VEGF therapy. So can we use OZURDEX in naive patients? It is not a contraindication. We can use it, and the recent data shows us a very good response, especially this article from Iglicki et al. Shows a significant response in improvement in visual acuity and central macular thickness following the treatment of naive patients with OZURDEX when compared to refractory eyes. The famous Escobar trial again showed us the same thing. It showed us that you can achieve on an average 1 ETDRS line improvement greater than in patients when you're treating naive patients as compared to patients who have been treated before by other agents for DME. We are always concerned about the safety of OZURDEX, particularly the IOP spikes, glaucoma, etc. So this is a snapshot from the MEET trial, which actually comprehensively analyzed the sequential injections and the IOP spikes in the sequential injections of OZURDEX in particular patients. They actually compared the IOP spikes of OZURDEX to sham injections. If you look at injection 1, you will find that there was a mean increase of IOP of 4 millimeters of mercury at around 6 to 8 weeks of duration from the injection of OZURDEX. As you see, as the number of injections go on increasing, these spikes actually go on reducing. Most of these IOPs are very well managed with topical medications, and very few patients would require surgical intervention. This was a very interesting article which was published less than a year ago by a couple of institutes from France, which actually analyzed the data from 227 eyes from 152 patients who were treated for DME with OZURDEX, and they followed these patients for up to 5 years. So Metis et al. Were actually supposed to look at the mean change of base-corrected visual acuity from the baseline for up to the follow-up period. Their secondary outcomes are supposed to be the change in central macular thickness, the number of injections these patients received, and any adverse events coming out of these injections. When you look into the functional efficiency, which Metis et al. Concluded, the mean maximal gain in visual acuity was found to be 12.3 letters at the end of 5 years. And the best part was the best responders, 82% of the patients actually responded very well to just one injection. Another finding that came out of this particular study was that the best response was found when the patients were followed up from 3 to 5 years. So you do a long-term follow-up, you can see a better response rather than the patients who drop out of follow-up. Correspondingly, when you see the data of reduction in the central macular thickness, again, you see a better response between 3 to 5 years. The study also showed that 62% of the patients had significant anatomical response at the end of follow-up, and 37% of the patients had complete resolution. When it comes to safety, the IOP was found to be 25 and above, and only 14% of the patients. And all these patients were managed with topical medications. None of the patients required filtering surgery. When you talk about retreatment, the DEX implant was the mean number of DEX implant required was 2.6. The mean time of retreatment was 6.9 months. The retreatment time was less in the first year, and as you keep following up these patients in the longer duration, the retreatment times keep on getting prolonged. So to conclude, an early switch to OZURDEX has shown a more effective response in the management of diabetic macular edema as compared to continuing sequential anti-VEGF injections in the patients who have not responded to initial therapy of anti-VEGF. DEX implant can be selectively used in naive patients. Real life practice has shown us an excellent outcomes of vision gain with treatment of DEX implant in DME. And as far as IOP spikes are concerned, most of the cases can be managed with topical AGMs, and most of the patients' IOPs come back to normal. If you look into the historic data, there have been very few patients who would require filtering surgeries when it comes to IOP spikes. Thank you.
Thank you very much, Dr. Mandeep. Very nice presentation, excellent, comprehensive. If there is any question from our panelists to Dr. Mandeep about his presentation.
Yes, Dr. Mohammed, Assalamu alaikum.
Salam.
Thank you, Dr. Mandeep, for your very nice and excellent presentation. I just would like to ask you regarding, you elegantly mentioned that the early shift after 3 injection is usually carrying a good, an excellent outcome. Did you came across any study comparing the shifting after 6? Was it whether is it differ from the 3? As you know that in our practice, the usual shifting is after 6 injections.
Initially, the response was like we used to classify the patients on the basis of initial 3 injections as good responders and poor responders. So the poor responders, there was a fraction of patients who would show us late response. And that is the reason we used to carry on giving injections despite of getting a poor response with initial 3 injections to up to 6. And then we used to shift or take a further decision. But these articles actually showed us that even with the patients who have not shown good response with anti-VEGF therapy initially, we can very safely shift them to OZURDEX and they give a better response rather than continuing on another 3 injections of anti-VEGF. But I think when you look concretely to all the evidence, it is balanced. So the choice is finally of a physician, and depending on his experience, whether he wants to keep continuing for another 3 injections or go ahead and do an intercategory switch.
Is there anyone who is having any experience to comment about question of Dr. Muhammad Azazi, Dr. Ahmad, Dr. Amr? Is anyone have any experience in that? You would like to shift after 3 injection or 6 injection? This is the controversy most of the time. But if we divide the patient to those they are poorly respond or non-responder, I think most of us now agrees is 3 injection we have to shift. But if there is a response, but not that much, then it is, I think you can go further. I don't know if there is anyone have any different opinion. Dr. Ahmed, Dr. Amr, what do you think, Amr?
Actually, I have one case like this I will present after a while, so
okay. So we keep this one for your.
It's fine. It will be the same debate, but I really, in this case, I shifted after 3 injections. So this is usually what I'm doing, because I think if you have a lot of edema, this will affect the vision. So if you waited a long time, at the end result of the patient for the vision, it will not be good. So so we have to give it a try, not to wait until 6 to then we shift for the OZURDEX. This is my opinion.
Okay, Ahmed.
But I didn't see any study about this really.
Excellent discussion and a very beautiful presentation, really. So thank you so much. My point is that, and again, I don't know the answer really, but what happens is that usually we switch to another anti-VEGF unless the patient is pseudophakic or they don't want to come back so frequent or something. But usually my first switch is another anti-VEGF. So that makes OZURDEX a little bit, used later on. For me, that's what I do. But I like OZURDEX. I think it's a great medicine. The problem is it's a pressure rise. I think the MEET study gives the most accurate long-term data for the pressure rise, which is in the range of 30%. And it's true. And I think very rarely maybe 1% of patients may need surgery. So usually it's manageable, but they may need one or more drops. So that's, I think, the concern. It's not like a big concern, but it's still a concern.
Dr. Ramzi, if you have any comment about that?
Yeah, maybe I would like to learn all the panelists and speakers' daily practice. So what's your primary indication, primary OZURDEX indication in naive patients? For example, if patient has macular serous exudation, serous detachment, that we know this kind of inflammatory biomarker. So do you apply naive this patient as a first choice of OZURDEX or the other indication? Mandeep, maybe I can start with you. So also Dr. Ahmed Salam's ideas or daily practice, I would love to learn. Also the others.
Okay, Mandeep.
Yeah. So Dr. Ramzi, basically, there are very few clinical parameters which which would qualify that we would actually go ahead and give a naive patient OZURDEX. Probably only a small central cyst with neurosensory detachment, patient presenting for the first time, and you can see those inflammatory, white dots kind of a thing in the subretinal space. Probably that is the only indication where I might try it in the naive patients. These studies, which I presented, actually spoke about all kinds of DMEs, not only what I am saying. But I personally don't have an experience in it. I would always prefer to go in with 3 injections of anti-VEGF and then decide. So there have been a couple of patients which we have tried OZURDEX, especially off late, because we don't want patients to come to the clinic because of COVID and stuff like that. They've had good response, but I don't know the longevity of this treatment actually.
Okay. Anyone have any other opinion different what you hear until now?
We use it as a first line in pregnant females, patients who also had like stroke or heart attacks in the last 3 months. We feel very wimpy really using anti-VEGF in these cases. And I think, yes, it works. It works very well for chronic edema. So if there's a chronic edema has been there for a long time, then I may use OZURDEX as a first liner, especially if the patient is pseudophakic.
Good.
Okay.
So in my practice, actually, maybe we cannot find this in the literature or other studies, but in patient, when we look at the ultrasonography OCT findings, in some patients we observe chronic signs of OCT in type of macular edema, such as intraretinal cystic change and something like that. And in this group of patients, and also in this patient, the retina is stable and the laser is already done, but there's significant macular edema, long-term macular edema. If I see this patient, this kind of patient, I usually prefer OZURDEX as a first-line treatment, and really works, and maybe in this patient it works better than anti-VEGF, because in this patient there's the VEGF load in the vitreous is very low. It's a chronic edema and there's chronic signs of OCT, and in such patient I prefer as a first-line treatment. What do you think about this kind of case, Mandeep?
Frankly, I would just go in with the clinical parameters, Dr. Ramzi. So whether it's a chronic case or an acute case, the dictum is to go ahead with anti-VEGF and then switch. But yeah, if you have patients with cystic changes, and if you have patients with small neurosensory detachments and signs of inflammatory mediators acting on the outer layers, then definitely I would go ahead and treat these patients early, irrespective of the fact they're acute or chronic. But it's a nice comment. I never looked into that aspect, that what would the response in the chronic CSMEs as compared to the acute ones with OZURDEX.
Thank you very much. Just I have only one small comment, or maybe a question, but if there is any comment, a fast comment, because already we are behind the time for the first speaker. Do you think in the era of COVID, maybe we need to give, more, or to think about like OZURDEX, so it will give more time, so patient will not come so frequent. So many things, it will decrease the patient coming and going into the hospitals. Does that make a difference with you, doctors here? Anyone?
I think it's a valid point, but the problem is they need to come back for a pressure check as well, and that's why I think that defeats their long-term.
But you will bring them most probably. Do you, Ahmed, give anything before you give OZURDEX? I mean, did you check for any response if there is an steroid responder or not?
I don't, because we really did a study on uveitic patients, and we found that there's actually, it doesn't tell well. I know there are like several thoughts and a couple of studies that show they can give an indication if you give them topical steroids, but actually we don't find that. So I do not.
But I mean, there is a real patient, they are a very responder. I mean, well,
yes.
responder to that one. If you give even topical, it will show, so you will be away, you will not give.
Yes,
but
if you know that
they are not,
responder,
you cannot tell it is going to have a high or not, but most probably not. Most probably not.
Yeah, 66%.
Yeah.
We should bear in mind that if you...
I think we will have also still Dr. Amr he will show us his experience, then maybe we'll have a further discussions. So now we'll have Dr. Amr Farid talk, and he's going to talk about OZURDEX in real life company.
So just a second. So now you can see my screen, right?
Yes, Dr.
Okay. So I'll just present some cases of my cases having the OZURDEX and the real life cases. So this is the patient. Okay, this is the patient, 61 years old, presented with vision decreased vision in both eyes. He's diabetic and hypertensive since 15 years. He had focal some laser treatment. He was 20/40 in both eyes. Anterior segment was fine. Just a second. Okay, this is his fundus exam. You can see some exudates there and the focal marks here as well. This is the OCT in the right eye. You can see some macular edema and the OCT in the left eye as well, but it is less than the right eye, as we can see. My decision at this point that I will go for anti-VEGF injection, which I believe all of us will go for this right now because it's a straightforward case. And this is the OCT after the anti-VEGF injection in the right eye, and also the left eye after the anti-VEGF injection. It went fine and everything was okay. Later on, 2 years later, the patient had some progression of the disease. He has cardiac catheterization since 9 months. He had stroke since 4 months, and he was complaining of decreased vision in the right eye to reach 20/150. Anterior segment also showed the progression of cataract in both eyes, and the posterior segment exam was progression to proliferative diabetic retinopathy with MVEs in both eyes. This is now the OCT for the right eye. It's the edema. You can see it is increased than before. And according to what we saw in the history, that the patient had a stroke, recent stroke, and he was a cardiac patient also, I prefer to inject OZURDEX for this patient and do cataract surgery. This is the left eye OCT. So the left eye was fine at this moment, and we didn't interfere except with some laser. So the management was that we do OZURDEX in the right eye, and cataract surgery was done in the right eye after 1 month of OZURDEX, and then PRP was done in both eyes. This was the serial of OZURDEX injection. This is before the injection of OZURDEX, and this is 1 month after injection, and this is the 3 months after injection. The patient went fine after the treatment, and the vision improved to 20/30 in the right eye, and the retina was stable after the BRB and regression of the PDR. So this is one of the main indication of having OZURDEX injection is to in the patients who are cardiac patients or pregnant patients or in patients that had recent strokes. You are more safe to go for the OZURDEX rather than anti-VEGF. Although that this patient before he was responding well to the anti-VEGFs, but I rather believe at this moment that the OZURDEX was a better choice. In case number 2, there is a 55 years old complaining of decreased vision since 6 months, and he also 15 years of diabetes. He's uncontrolled, and he didn't treat his retina before. The HbA1c was 9. Visual acuity was 0.4 and 0.3. He has some nuclear sclerosis, and the IOP was normal. Posterior segment shows non-PDR with macular edema. This was the right eye having some exudates here, and the left eye as well. The periphery, you can see. But this is the OCT for the right eye. It's a little bit of huge edema with some subretinal fluid, as you can see. This was the OCT in the right eye, and this was the OCT in the left eye, which was more as well, having more edema than the right eye. So again, I decided to do anti-VEGF injection as a start. So this is the right eye after the first, before injection, and this is after the first anti-VEGF injection. I didn't see that much improvement. And after the third anti-VEGF injection, I didn't see any improvement. And this is the point that we were discussing a while ago, that you will wait for how long to shift to another drug, either anti-VEGF or other steroids. I don't believe that this huge edema, you cannot wait for it for a long time. So at this moment, I decided also to shift the patient to OZURDEX after the third anti-VEGF injection. The left eye as well, it acts nearly the same. This is the before the OZURDEX. This is this is the after injection of OZURDEX. This is after 2 weeks only after OZURDEX, and this is after 1 month only. And you can see there is dramatic decrease in the edema, which we didn't see at all with the anti-VEGF with these patients. It doesn't mean that we see also a dramatic response in a lot of patients with anti-VEGFs, but sometimes there is a more inflammatory mediator that you need to deal with the OZURDEX or the steroids. My point is, if you waited long time, you will lose vision for this patient. This patient also, he had starting cataract in both eyes, so he was willing to do the cataract surgery as well, which he did later on. The left eye also acted the same. This was the OCT before the anti-VEGF injection. This is the second. This is after the first anti-VEGF injection, and this is the third after the third anti-VEGF injection. So you can see at nearly there is no response for after the 3 anti-VEGF injection, although they were successively given in 3 successive months. And again, it went well after the OZURDEX. The same response as we saw in the right eye, we see here in the left eye, and it's only after 1 month of the OZURDEX injection, there was a really improvement in the macular edema. So this patient, he has improved to 0.8, and he had cataract surgery done actually in both eyes. And patient had around 4 injections of OZURDEX over 2 years. He was fortunate from the 66%, he didn't have any increase of IOP. Of course, some of the patients we inject OZURDEX, they have increase in the IOP, but it's really manageable with the drops only to manage this increase in the IOP. My third case is a 66 years old female, which has decreased vision in the right eye. Her vision is 0.1 in the right eye and 0.8 in the left eye. She had really posterior subcapsular cataract actually in the right eye, which is affecting the vision, and she had cataract surgery before in the left eye. Hello? Hello, you can hear me?
Yes, Dr. Amr, you can go ahead, please.
Okay.
We are here, please.
Yes, okay, because I thought it's done. This is the OCT in the right eye. We can see also a macular edema with some subretinal fluid. It is not that much as the previous case, but in this patient, she didn't like to go for injections a lot, and I provided her, I gave her the opinion, the option of having OZURDEX, and she agreed about it. And this with the left eye was fine. We didn't do anything about it at this moment. So OZURDEX injection was done in the right eye, and also cataract surgery was done after 1 month of the OZURDEX. So this is before the injection. This is 1 month after the injection, and this was 3 months after the injection. It worked well with this patient. And the OCT recurred again after 4.5 months. We can see here this cyst recurred again. But again, we injected the OZURDEX again in the right eye, and it went very well. But now it went for a longer time, which actually lasts for about 6 months of injection. This was the OCT after the 6 months, and the condition of the retina was really stable. After some time in this visit, the left eye was having also this edema again. So I suggested OZURDEX because I saw it's working with the patient. And my experience in the right eye, that there was no increase in the IOP. And this was really after 4 months after the injection. So the vision in both eyes improved to 0.9. Patient had 3 OZURDEX injections during 1.5 years in the right eye, and she had 2 OZURDEX injections during the same period in the left eye. Patient didn't have any increase in the IOP as well. So again, OZURDEX can be used in a naive patient also from the start. If you are suspecting that there is subretinal fluid or the inflammatory mediators or inflammatory signs, you can see it, you can go for this. So OZURDEX has a rapid mode of action, as we saw in one of these patients, and the early switch from the anti-VEGF to OZURDEX, if the patient is not responding or having a suboptimal response, OZURDEX is favorable, of course, in treating patients with macular edema with recent strokes and the cardiac catheterizations, and OZURDEX is favored in treating macular edema with cataract surgery to be injected 2 to 4 weeks before surgery. Usually I do OZURDEX if I have active PTRs. I usually go for anti-VEGFs along with cataract surgery. But if the patient will go for cataract surgery and is having macular edema, I prefer OZURDEX, as it will also cover the inflammatory component during the cataract surgery. Thank you so much.
Thank you very much, Dr. Amr, for this excellent presentation. Very nice cases, and I think the discussion is open. Is there any question for Dr. Amr about his cases or any points that he mentioned during his presentation?
Yes,
Dr. Muhammad?
may I, Dr. Muhammad?
Yes, please.
Yes, thank you, Dr. Amr. Very nice and excellent presentation as usual. My question is to you, Dr. Amr, and maybe to all the panelists, and I would like to hear it very clear from everyone. Some physician or treating retina specialist, they do advocate for going with combined treatment rather than shifting to monotherapy instead of shifting from anti-VEGF to steroid alone. They continue on anti-VEGF and they add steroid. So does anyone advocate for this, and he has experience regarding this maneuver?
Dr. Amr, if you have answer.
I had before with triamcinolone, we have experience with the triamcinolone, but for the OZURDEX, no, I didn't have this experience, as we have a problem, of course, with the insurance. You cannot have approval for both of them together. It's very difficult to have approval for them together, and at the end you will not know which one worked for them. Also, there was some studies about the counteraction or some inflammation that might happen with one anti-VEGFs along with the steroids before the triamcinolone. So I didn't try actually to inject both of them. But what I really tried that sometimes with the OZURDEX, you inject the patient with OZURDEX and the patient gets used to it, and then you cannot see the response that you were seeing this before. So at this time you might shift again to anti-VEGF and you might find the response. So I had it in some patients that I cannot they are not improving that much again with the OZURDEX, then while shifting into anti-VEGF they're gonna improve.
Any comment, Dr. Ramzi?
I have a few cases, Dr. Hazai, in this group. But if the patient has no good response to anti-VEGF, and then if there is no good response to OZURDEX, and these are very few cases, I combine together OZURDEX anti-VEGF at the same session. And I can say that maybe I have like 3 or 4 cases, something like that. It's not so much. One of the cases that I follow more than maybe 8 or 7 years, and it is combined treatment because the response was not good, both anti-VEGF and OZURDEX. So in this group of patients, I applied this, and I can say that the combination treatment is more effective than anti-VEGF and OZURDEX alone. But these are very few cases.
How do you apply this one? You are giving at the same time or what?
Yeah, at the same time, because I assume that we should reduce VEGF load and also inflammatory load in the vitreous at the same time. Therefore, if I decide to do this, I give injections at the same time, at the same session.
Okay, Dr. Ahmad, Dr. Mandeep, anyone have any comment?
Yeah, thank you so much. This is a great presentation, Dr. I'm afraid, really beautiful. I have a few points. I have actually experience with this. Usually, which was actually published before, is you see some, if you go from anti-VEGF to steroids to anti-VEGF, you may see some bit more improvement of macular edema, but usually the vision does not improve. And I have only very few patients like this. Similar to Dr. Al-Farid, we cannot combine the two medications because of insurance. But we've done several patients where we gave Iluvin, like patient had chronic edema, so we gave another steroid that's more longer acting, Iluvin, for example, and then we went back to anti-VEGF. So we did this as well, and I think that helps. So it definitely seems that the combination of the two probably helps a bit, at least. One last point is I like also OZURDEX with surgery, so I combine it during cataract surgery and also during vitrectomy surgery. And I think it's really very nice to cover the disease as well to combat the inflammation post-surgery. And we do this in uveitic vitrectomy and diabetic vitrectomy as well.
Any other comment, or Mandeep, you have any comment?
Yeah, I would just like to come back to Dr. Amar's second case, which had the very high macular edema. First of all, it was a very good presentation, Dr. Amar. And if this was patient with me, I was thinking, when I was in India, I would have gone ahead and done an angiography for this patient. And if I find wide areas of capillary non-perfusion, I would give an option to this patient to go ahead and do OZURDEX in combination with anti-VEGF therapies. So back in India, we used to do it quite often. The option was always given to the patient, and we had fabulous results with combination therapy. That's my experience, than independent therapy. And of course, here in UAE, we are bounded by department policy, so we can't do that. But yeah, they work. They definitely work very well.
Thank you, Mandeep. I think I will have a small comment about Dr. Ahmed, last comment about if you have Iluvien. I think you are meaning top-up of the patient. It's
Correct.
Not on the same time, not on the same time.
No, we cannot do it on the same.
Yeah, that means it's not combination. Okay.
Yeah.
Okay, thank you very much. Thanks, Dr. Mandeep. So now we can move to my dear friend, Dr. Ramzi, and he will give us a talk about challenging and controversial points in the treatment of giant retinal tear detachment.
Thank you, Dr. Mohammed. I think you can see my screen.
Yes, please.
Okay, I will speak about the giant retinal detachment, especially challenging and controversial points. But there are, as you know, many challenging and controversial points in the treatment of giant retinal tear detachment. These are my financial disclosure, but none of them are related with the content of this presentation. As you know, giant tear retinal detachments is the circumferential retinal tears of more than 90 degrees, and they comprise almost 2% of all retinal detachment, and they are more common in males. Almost 3 out of 4 patients is male, and the average age of incidence is about 40 years. And the main etiology is idiopathic group. More than half of the patients has idiopathic etiology, and the second biggest group is high myopia, ocular trauma, and also hereditary conditions are the other etiologic factors. So there are great challenge due to the high risk of intra and post-operative complication and the many technical difficulties before. But recently, the advent of modern vitrectomy techniques and also especially the PFCLs has provided new opportunities for the treatment of giant retinal tears, and the primary attachment rate is increased from about 58% to almost 100% today. So there are different treatment alternatives, but the vitrectomy without sclerobuckle is more widely accepted and used today. And we can apply normative retinopexy, especially small giant retinal such as 90 degree or 100 degree and superior location. and again, only scleral buckle again, small giant retinal tear, which is not localized retinal, combined with localized retinal detachment. But except this limited case, we usually prefer vitrectomy in all cases. So there are many challenging and controversial points, as I mentioned: buckle or not to buckle in this patient, preserving the crystalline lens, unfolding the retina and unrolling the retina, removing of anterior retinal flap, laser photocoagulation, preventing posterior retinal slippage, and tamponade choice. So buckling procedure is really one of the biggest controversial point. So it's not clear if there's any benefit of combination vitrectomy with circumferential scleral buckle. And today, the vast majority of giant retinal tears were treated with vitrectomy alone. Only 8% was combined with inserting buckle on the literatures. And when you look at the comparative results in terms of primary attachment rate with vitrectomy and vitrectomy buckle, and there's no significant difference between the groups. And also, again, the reoperation rate almost same, even worse in combination vitrectomy and buckle group. So the final anatomic success rate seems to be also equivalent in both groups. Therefore, scleral buckle is not routinely recommended in eyes without PVR, since it may cause retinal redundancy, guttering, and slippage during the air fluid exchange. But it favorably used to support vitreous base and decrease the traction force in case with pre-existing PVR, or in other cases with phakic patient in whom the crystalline lens hinders complete vitreous base cleaning. So what about the preserving crystalline lens? Considering the young age of this population, we are usually in favor of protecting the lens. Actually, lensectomy is not necessary for the vast majority of cases. And vitreous study also reported that no significant difference between lensectomy and the non-lensectomy in the rate of redetachment or visual acuity outcomes. And on the other hand, technically, it's more difficult to clear anterior vitreous in phakic patient without touching the retina. What can do and what can pay attention to prevent this complication? It can be done by applying trocar infusion 4 millimeters from the limbus, not 3 and 3.5. And also chandelier illumination we can use, also extreme scleral adaptation. Chandelier illumination help us to work bimanually and to do our own indentation, because this is the safest way to do our own indentation as a surgeon and to control everything. As you see here, with extreme scleral indentation in phakic patient, this is 7-year-old boy, we can reach to the ora serrata and clean the vitreous space. So what about the unfolding retina? A soft tip cannula can be facilitate unrolling the residual area of retinal foldings. Also, during the attaching the retina, we should pay attention to inject PFCL gradually and slowly over the optic disc to ensure that a single enlarging bubble expands and past the peripheral edge of the tear to prevent subretinal submacular PFCL complications. And the other things, they also we observe retinal rolling on the edge of posterior flap, as you see here. And this signs of early PVR. In this pain peak or soft tip cannula, also feels slow to unroll the retinal overs. The other point is removal of anterior retinal flap. As you know, the anterior retinal flap is devitalized ischemic retina that can serve as a scaffold for anterior PVR, and therefore, in all of the eyes, anterior retinal flap need to be truly removed, as you see here. And usually we pay attention for this tilt ora serrata. We remove anterior retinal flap with indentation, especially in phakic patient. We need extreme indentation to be able to do this without touching the lens. However, there is some exceptions. What is the exceptions? For example, this patient, there are 2 giant retinal tears. One of them is very posterior located. If we would remove, if we would remove this patient, all the anterior retinal flap, there will be large area of retinectomy. So how you treat these eyes with very posterior located giant retinal tears? Do you think that we need to preserve anterior retinal flap on the nasal giant retinal tears to prevent potential chronic hypotony complications? So there have been no studies directly comparing the size of giant retinal tear and the change of intraocular pressure, but we know that in giant retinal tear detachment, we observe chronic hypotony between 13 to 19% after surgery. So in this patient, in such patient, in my practice, I try to prefer anterior retinal flap. This is not easy, but not necessary in all cases, but very few exceptions we can do this. For example, this patient, and after co-vitrectomy, I inject PFCL to the posterior pole to stabilize the retina, then unroll the edge of the retinal flap, then remove the anterior retinal flap on the temporal retinal tears, but on the nasal one, I apply a fluid air exchange and remove the vitreous from the anterior retinal flap under air. I think this is the only way to be able to clean the vitreous from the anterior retinal flap. Then we dry the retinal fluid, then do laser, then give more anti-VEGF and PFCL, and attach the anterior retinal flap. As you see here, is about 120 giant retinal tears, and we managed to attach the anterior retinal flap, then give silicone oil and remove the silicone oil about 2 months later after surgery. As you see, the retina is completely attached. Even also the anterior retinal flap is attached. There is no PVR problem. So in such patients, these are very few cases. If we think that after large retinectomy, we can have chronic hypotony complication, we can use this modified technique to reattach the anterior retinal flap and to get a good results. What about the laser photocoagulation? This is another controversial point. Do we need to do laser 360 or laser only around the retinal tears? So the results not really different. In my practice, I prefer laser only around the retinal tears, but we should pay particular attention to the radial edge of retinal tears, treating anteriorly up to the ora serrata, where primary failure most often occurs, as you see here, and this area, one should pay attention to the good laser, especially this area. This is important. The biggest point, maybe complication, maybe or challenging topic is posterior retinal slippage during fluid air exchange. As you know, this step is arguably the most critical step, and to prevent this complication, it's essential to remove all the fluid anterior to the PFCL bubble meniscus with a soft tip cannula before removing the PFCL. Sometimes you may need gentle aspiration, manipulation to the retinal flap with soft tip cannula to place the retinal flap, as you see here. But in this step, we should give time to dry all the fluid anterior to the retinal flap to prevent this complication. So there's also a negative relationship between retinal slippage and scleral buckle, because the convex curvature of the eye induced by scleral buckle can cause significant retinal slippage during fluid air exchange. Therefore, if we plan to do scleral buckle, we should do buckle better after fluid air exchange to prevent this complication. So the other things, in case with slippage following fluid air exchange, we may prefer silicone oil tamponade, because sometimes it's not possible to prevent the slippage, especially large giant retinal tears, such as more than 200-degree giant retinal tears. And in this patient, we can prefer directly silicone oil tamponade without the fluid air exchange, because PFCL silicone oil exchange is less likely to cause the slippage, because silicone oil has hydrophobic properties of both PFCL and oil, and therefore we can prevent this complication with preferring directly silicone oil tamponates. So what about the tamponade material? It depends, gas or silicone oil. It depends the location of the giant retinal tear and also presence of any residual traction after membranectomy in case with PVR. In the literature, these are the silicone oil indication is the first one is primarily inferior giant retinal tears more than 180 degree. This is a controversial point in my practice. I do not prefer silicone oil in this group of patients. And the other indication is slippage following PFCL air exchange. Yes, this is really sometimes we need this if we couldn't manage the attached retina, prevent slippage during fluid air exchange. You can prefer silicone oil. The other indication is giant retinal tear fails to remain flattened after membranectomy and retinectomy, and the other is bilateral patient, and the other is poor compliance with positioning. So I think the real indication in this group is slippage following PFCL air exchange. Maybe you can try many times this PFCL air exchange. Still, these complications continue. You can prefer silicone oil. And except this, maybe bilateral case, we can prefer also silicone oil, but the other is relative indication. And in my practice, I do not prefer silicone oil because of red PVR complication. If there's PVR, if there is not, retina is not attached perfectly, I prefer radial retinotomy maybe instead of silicone oil tamponade. But we should prefer long-acting gas such as 12 to 14% C3 F8, not short-acting gas. These are some patients from my series, and in all of these eyes, I prefer gas except one eyes, and this patient was bilateral giant retinal tear, therefore I prefer silicone oil, but usually I prefer gas, long-acting gas in giant retinal tear detachment, except if there is severe chronic PVR, I can prefer silicone oil. What about the complication? We already managed some of these, but maybe we can speak about the submacular PFCL complication, also PVR. Submacular PFCL is usually happen during the after the fish egg formation in PFCL due to the jet stream flow during injection or during indentation and releasing indentation. Therefore, we should pay attention to slowly inject PFCL, keeping the tip of the needle inside of the PFCL bubble. Also, we can reduce bottle aid in gravity system during the working. Also use a large diameter infusion cannula to prevent jet stream infusion. And also we can gradually remove the indentation power to prevent hypotony, sudden hypotony also during the indentation. And when you release the indentation, the infusion can come fastly and may create a jet stream and may cause fixed X formation. These are the caution to prevent this complication. But when it happens, how can we treat this? This is kind of this patient referred to me from another city. As you see, there's several PFCL bubble. OCT, you can see two big bubble, but fast OCT show us perfectly all the PFCL bubble. There are four different sizes of PFCL bubble, as you see here. And also when we go to operation room, we observe that there are many intravitreal PFCL bubble in this patient. And then first we remove these PFCLs and then try to remove subretinal PFCL. For this patient, especially if the PFCL is located on the macular area, it's not possible to remove this PFCL directly inserting the 41 gauge cannula over the PFCL bubble. Therefore, I prefer to create retinal detachment with 41 gauge cannula with injection subretinal fluid. Then I bend the tip of 41 gauge cannula and go to the subretinal space little far from the PFCL bubble, as you see here, and I apply tangential approach to the PFCL and try to remove this. So for the other one, I will create another insertion to the retina with more injection and detaching the retina, as you see here, because the small bubble is very close to the foveal area. If you go directly, we can touch the RP and make RP damage, and this may prevent visual functions. So as you see here, after detaching the retina macula, so we managed to remove all this PFCL bubble. These are after surgery. This is for multicolor, and this is ultrasound OCT, and this is emphase OCT. As you see, there's still small bubble of PFCL here, but most of them is in the macular area is removed. What about the PVR? And in most of the patient, we can observe PVR, and I will show you a very difficult case with traumatic case, and there was very severe trauma. There are almost 180-degree perforation parallel to the limbus. After primary procedure, we go into the vitreous cavity about 3 weeks after surgery. As you see, this is complete total funnel shape retina and almost 300-degree giant retinal tear. All the retina was attached to the nasal part of the to this ora serrata vitreous base. And in such patient, we should remove all retina 360, then give injection. This after silicone oil. Then we remove silicone oil, we insert a scleral fixated intraocular lens. This is the fundus after the second surgery. And this patient, I operated this patient almost, I think, 8 or 10 years ago. Still the patient keep 0.2 vision. Sometimes if the patient can see the light, we should go and do some things as you see in this patient. But in such patient, we have to prefer silicone oil because of we need long duration of tamponade, as you see in this case. So in summary, the key point in the management of giant retinal tear is injecting PFCL as a single bubble to prevent supraretinal PFCL complication and removing all anterior retinal flap truly. There's some exception in some case, maybe we can prefer modified technique, as I mentioned. Also identifying all distant breaks and removing of all anterior fluid by drying the edge of break truly to prevent retinal slippage, and laser photocoagulation to the radial edge of the tear anteriorly up to ora serrata, especially the edge of the tear, and preferring additional scleral buckle in case with choreastic PVR, but it depends on the severity of PVR, and focusing and optimization of each step of the procedure to get successful results. Thank you for your attention.
Thank you very much, Dr. Ramzi, for this such a very interesting and excellent presentation. Really was very nice with good also explanation, very nice videos, and you have tackled, I think, most of the point related. But anyway, there is, as you mentioned, many controversies about this one. We can hear our panelists. Also, we are having many of our colleagues. They are with us as attendees. So any one of them, they want to participate with us, he can just raise the hand and he can join us as for these discussions. Okay, is there any comment or any question from any of the panelists to Dr. Ramzi? Okay, any one of you, Dr. Muhammad or Ahmed, any one of you?
Please go ahead, Dr. Muhammad.
Okay, Dr. Muhammad.
Go ahead.
Okay, well, thank you so much. Ramzi, this is a fantastic presentation. You've touched all the points, so really second to none presentation. Well done. 2 points, or actually mainly, yes, mainly 1 point. I use perfluorocarbon liquid as a tamponade in inferior giant retinal breaks. And also if the breaks, if it's like extending more than 200 degree. Do you have any experience with this? My argument that this is a nice technique is that it simplifies surgery. There's no slippage. You just put the PFCL laser and then you come 10 days and you have a chance to look at your work and add more laser if need be, and then maybe just leave air in the eye. And it works so well for me. What do you think about this?
Thank you, Dr. Ahmed. This is another option, of course. And I tried this in a few cases a few years ago. But then I also try heavy silicone oil in this patient to if the giant retinal tear inferior. But in this procedure, I observe more PVR complication comparing the other one. And therefore, Actually, I do not prefer this technique, and usually, as you see, I prefer long-acting gas in most of the patient in my practice. Even patient has limited PVR, but if the patient has severe PVR, if there is circumferential tractions, I prefer in that patient silicone oil. But actually, I do not do this technique that you mentioned anymore because of PVR complication. Especially in heavy silicone oil, it really creates severe PVR in the superior retina. And it's really difficult to treat superior PVR than inferior sometimes. And therefore, actually, maybe I have not enough experience. I tried this in a few cases. If I would continue, maybe I would get success, but PVR complication usually afraid me to do this procedure and then to continue this procedure.
Ramzi, my point is not on densiron, it's on leaving perfluorocarbon liquid.
I understand.
Yeah,
leaving perfluorocarbon also
it's inflammatory.
Yeah, it's really great inflammation. Also, this may create PVR. But as I mentioned, I have a few cases and I tried this several years ago, and therefore maybe I cannot say that I have enough experience. This is more true than maybe, yeah.
Thank you.
Welcome.
Okay, Dr. Muhammad.
Yes, thank you, Dr. Ramzi. Again, very nice presentation as usual. If we are dealing with giant retinal dialysis, does the use of buccal has any role in your approach in treating such patients or no?
Giant retinal dialysis without detachment?
With detachment, yes.
With detachment. Yeah. So buckling is another option, but again, in my case, I almost never combine vitrectomy with buccal in giant retinal tear detachment. So I tried this again in my previous case, but in my experience, I do not think that buccal give any additional benefits, because also it may create provocate slippage and also the other problem. Therefore, actually, I do not use circumferential buccal in giant retinal tear detachment.
Was the question, Dr. Azizi, about dialysis or retinal tear or giant retinal tear?
No, sometimes you have dialysis, but it's actually extending more than 90 degrees, and as you know that the buccal works very well with dialysis. So
yes,
if you are dealing with such patients with treating the detachment related to dialysis, as it comes in your mind that I will use the buccal as a supportive measure to support at least the vitreous space?
Maybe let's clear that if the giant dialysis with a limited detachment or total detachment. So if it's total detachment, it's the giant retinal tear detachment or dialysis detachment. And I mentioned this patient, but if there's limited detachments, so maybe we can try buccal. But if we go into the vitreous cavity, this is my surgical technique. If I need to go into the vitreous cavity to treat the patients, and in such group of patients, I do not prefer buccal. I do everything in the vitreous cavity and finish the release membrane and attach to retina and do laser and tamponades. But if we think that we can treat this with without vitrectomy, so maybe we can prefer buccal, but usually I prefer vitrectomy.
And did you find any difference between the gauge size 25, 23 and the success rate?
Actually, I use 23 gauge, also 27 gauge, but I do not have experience with 25 gauge. 27 gauge is very flexible, and it's not possible to do detachment surgery and PVR case. And usually prefer 23 gauge in these patients because it's more rigid and you can control everything during indentation, because you can reach to vitreous space with 20 gauge more safely than flexible 27 gauge. But maybe 25 gauge can be in between, but I have no experience with 25 gauge.
Any other questions for Mandeep or Amr?
So, Dr. Ramsey, I have a question. First of all, great presentation, very well concised. This is regarding flap slippage. We know that one of the major issues with the flap slippage is the time when it happens. You've done the vitrectomy, you flattened the retina, you're deciding to go ahead with the next case, go home, whatever. The last step, the flap slippage happens. So it's frustrating, right? So what do you do actually to deal with this? Once you have the flap slippage, would you actually try the Finis loop and try and reverse the slippage and drain the periphery of the retina? Or would you go back and do a PFCL exchange again? Or would you go back and do a vitrectomy around the, because you know flap slippage happens because of this thin film of water along with the vitreous in the periphery. How long back in the surgery would you go back?
You mean just after surgery where you see flap slippage?
Well, while you're doing fluid exchange.
During fluid
exchange, yeah.
So this is really, in my experience, the slippage is the most challenging problem as point in the giant retinal detachment. Sometimes I really cannot manage to attach to retina, and I prefer silicone oil tamponades. But usually prefer this slippage is large giant retinal, like more than 180 degrees, not a small giant retinal tear. And what I do if I see, I inject PFCL again until the edge of the retinal posterior flap, retinal, the posterior edge of the retinal flap, then dry the subretinal fluid again and with indentation, and try this many times and give time and to pay attention to dry all subretinal fluid. But if then when I continue to fluid air exchange and again if I see, then I try the same thing again, because we should dry all the fluid under the retina to prevent the slippage. But in phakic patient is really difficult. In a pseudo-phakic patient, you can manipulate more easily, but in phakic patient, it's really difficult sometimes. And in some patients, I prefer silicone oil. But the key point that I try many times, give more PFCL bubble injections and try to dry to retinal fluid again around the edge of the flap with soft tip cannula. Sometimes we need to manipulate the retinal flap with gentle aspiration, and because it may slip again, and you can manipulate and through the vitreous space. But the only way to give PFCL again to do one more if necessary. But if you think that it's not success, you can keep going. And if it is not successful, you should go directly silicone oil exchange, and it solves the problem.
Any question, Dr. Amr, or comment, please?
Actually, very nice presentation. Very nice videos. I have a comment only regarding the buckling, which I agree with you that buckling has no more benefit in treating these cases, because actually the purpose of the buckling is to create the circumference of the eye to help the retina to go back. In giant retinal tear, you have this already, and you can manage this from inside. Your retina is short already. You have your retina is cut, very giant retinal tear. So you have the ability, even if you have this inside, it's not back, you can increase a little bit the tear and it will come back as a retinectomy. You deal it as a retinectomy. So I don't believe that buckling in these cases have a more benefit. If you will work only from outside, you do buckling only from outside at the giant, but without the dialysis, without detachment, yes, this is applicable. But the other way, I really agree with you that we don't need buckling in these cases.
Thank you.
Thank you, Amr. Dr. Muhammad Hazazi, you have another comments or questions?
Yes, regarding the subretinal B4 bubbles, the retained subretinal bubbles, I actually have a few cases done with the same technique you just nicely mentioned. But the always concern is the visual outcome on those patients, because you are dealing with introducing the needle in the exactly subfoveal space. It's blindly introduced. Sometimes you may, iatrogically touch the photoreceptors or the RPE. Do you have any experience with comparing this technique with other technique, going only with creating the blip and injecting, for instance, short-acting gas? Patient either in 45-degree, the bubble will settle down away from the fovea or face down position.
This maybe only this technique that you mentioned can works in fresh case. If you see the bubble, subretinal PFO bubble in maybe a few days, like 1 to 3 days after surgery, it may work. But usually we cannot realize the subretinal PFO if we apply gas tamponade in this patient. We realize this several weeks later. In silicone oil patient, it's okay. But in gas injection, we see this bubble when this gas is absorbed and when we see the macular area. Therefore, in this period, it's too late to remove subretinal PFCL with this gas manipulation, because it creates inflammation, and inflammation creates a capsule around the PFCL, and it fixates the PFCL bubble on the submacular area, and it's really not possible. And therefore, in many patients, we see the subretinal bubble, PFO bubble several days after surgery, like weeks after surgery, and therefore, I don't think that this technique will work in these chronic patients.
Actually, I was lucky. I received one patient just recently, 3 weeks back. I saw him, a month post-op, and he had actually multiple pre-retinal or vitreal bubbles and subretinal, and I did only, created the blip, and I kept him with SF6. And he did very well. I saw him just a week ago. The bubbles are displaced away from the fovea, and his vision improved. Still, he has a bubble. This is why the vision was not the expected vision. However, at least the bubble are displaced away from the fovea.
So the other point, Dr. Zaid, in this patient, even we remove the subretinal PFO, usually vision not improve, because subretinal submacular PFO may cause toxic effect there, and in a short period after surgery, even we remove the PFO, the RP photoreceptors is really damaged on the macular area, and therefore, in my case, I have maybe more than 10 patients, because many complicated cases in our country refer to me, come to my office, and I do the surgery, and none of this patient has created a good vision after this surgery, and all this patient has really very poor vision, unfortunately. Actually, we do the technique and we remove the PFO, but not good visual results.
Thank you very much. Thank you, Mohammed. We will have one question, but before that, just I want to share with you. Can management share the screen with us, please? I want to announce for you one thing.
Management? You mean?
Our management. Can Marvision, can you share, please? Okay, this is just I want to announce that we are going to have tomorrow. Actually, we are participating with those Delhi Ophthalmic Society. They are for conference, and MEOM was invited. And tomorrow we'll have sessions that will be from 2 o'clock to 3:30 by UAE timing. And we are having a very eminent speaker with us participating in these sessions, representing MEOM, Dr. Usama Jleidi, Dr. Nazim Al-Hussein, Dr. Safwan, Dr. Ahmed Al-Khashab, and Dr. Walid Abdullah, Dr. Ahmed Al-Barqi, Dr. Lilian, and Dr. Habibullah I'timadi. So please be there if you are willing to, and we are having a very nice, and we will share with you after a while the invitation. So you'll find the link to join us, and we are going to be in Hall B from 2 to 3.5. Thank you for being with us today and being with us, inshallah, tomorrow. And we have only one question before that, from Dr. Ziad Hussein. He is asking if you have post-operative hypotony, did you leave the silicone oil forever, or what you will do?
So this is another problem, but if we have post-op chronic hypertony in giant retinal tear detachment, yes, we can keep the silicone oil inside of the eye for a long period of time. But before to decide this, we should check all the vitreous space again, if there is any contraction on the vitreous, ciliary body contraction, because yes, there's a controversial, the big discussion about retinectomy or the ciliary body traction or detachment. So I think in the literature, there are many studies support that ciliary body traction is more effective and more probably the cause of chronic hypertony. Therefore, if there's chronic hypertony problem, we should check all ciliary body 360 on the vitreous base. If there's traction in membrane, we can do and operate again. We can remove the membranes. But if we cannot see anything, we can keep the silicone oil for a long period of time. I have two patients, one eye patients, and one eye patient has silicone oil more than 10 years. But every 3-4 years, the silicone oil is emulsify and remove the silicone oils and give the new one because of hypotony, and I keep these patients like counting finger vision with this silicone oil tamponade. So sometimes we need to keep silicone oil inside of the eye years after surgery.
Okay, is there any question or comments? Is there anyone from our participants or attendees they want to ask any questions? We are having many eminent also speakers. They are with us as a participant, Dr. Ahmad, Dr. Barqi, Dr. Carlos, Nazim, they are all here with us. So I think, is there any comment from our panelists here, Dr. Mandib, Amr, or Muhammad?
Yes, I just want to share one of a case of mine with chronic hypotony. As Dr. Ramzi nicely mentioned, that the ciliary body detachment probably one of the main cause of chronic hypotony. So, and that patient, he was pseudophakic. He was after 2-time vitrectomy for rhegmatogenous retinal detachment and inferior 1/8 retinectomy. Although his retina was flat, and we kept following him for almost 6 months, his pressure did not go above 3 in best scenario. So I took him again to surgery. I removed the IOL, and I removed the cyclitic membrane around it, and I went with endoscopy. I inspected all the ciliary processes, and I removed all the membrane connecting the ciliary processes. Probably it was also contributing in pulling the ciliary body centrally. And I followed him. I kept him aphakic, and after some time, his IP went back to average of 12, 13. At least we kept the eye because there were no tamponade inside. So I don't want him to go into hypotony and eventually into phthisis, at least just to keep the eye cosmetically acceptable.
Thank you, Muhammad, for sharing your experience also in this situation. I think we came to the end of this session. I would like to thank you all. Thank you, Dr. Ramzi, Dr. Mandib, Dr. Amr, Dr. Muhammad Al-Hazazi, and also Dr. Ahmed Salam. And thanks for others, those they are participating with us and as attendees, well-known also speakers, they are with us. Thank for all participants, and we hope to see you inshallah tomorrow if someone have a chance to join us. And also on 23rd of this month, we'll have another session in Ramadan. Thank you very much and good night. See you all.
Thank you, Muhammad.
Thank you, Dr. Mohammed.
Thank you.
Thank you, everyone.
Thanks. you know.